Hey, good morning.
Good morning.
Dr. A. Hector.
Good morning.
Good morning.
So we don't have our sunshine this morning, which we all get spoiled in Florida, having sunshine all the time with this great lighting.
Mm-hmm.
So today the lighting's going to be a little subdued because we have this rainy weather today.
Yeah, mostly.
And we're back to talk about another topic, part of, these things that we talk about on a weekly basis that are buzzwords in our office, part of our culture. And it's also obviously applicable across the industry. And we all deal with these things internally, and we're going to attempt to kind of make it external so that you kind of know what's going on behind the scenes and how your doctors are making treatment planning decisions. So for today's topic, what's the buzzword?
Sway.
Yes, sway. So for me, when I think of sway, it's just such a concrete image. And what's interesting is I just assume that you had a concrete image in your head. And it's not a good thing to assume, right?
Yeah, it's a topic that to verbalize what it is, I know what it is, but verbalizing it, I've struggled. So you explained it wonderfully.
Yeah, and the way I explained it to Hector before as well is, I read a book a long time ago. The book is called Sway. Subject matter is they gave the example of the space shuttle Columbia. I think it was 1986. It exploded, right? And I remember it's like reading about this and then reading about it in the book after the fact was that this space shuttle was supposed to have taken off a number of times. I think it was like 7 times, and everybody's thinking, gee, when is it? We're all waiting for this to happen, or it's not going to happen again. And they're going through their diagnostics, and every time there was like a problem with the pressure, or it's a problem with the temperature, or is it a problem with something on the checklist. And you can imagine who's ever in charge of saying, okay, all right, today's going to be the day, and then something happens, they run through their checklist, and like, nah, it's not going to happen today. After a certain amount of times, there's kind of like an internal bias, which is like, it's going to happen, right? And so on this particular day, there was something that was off by just a little bit. And for that instant moment, the guy in charge had sway and said, you know what, I think we're going to go for it. And we all know what happened. So it happened to be a problem with, it was like an O-ring that had shrunk because of the temperature that day, causing a fuel leak, and tragedy within, I think it was like 72 seconds of this thing taking off. And obviously we all remember it today, especially if you were there. I mean, I was in my 8th grade class and saw this thing happen. So the author of this book put it so well, I just can't get it out of my head. And we have sway situations every day, right?
Yeah, that's right. Mainly when, deciding on what's going to be the best course of action and treatment planning.
And it doesn't feel good as a professional when you have sway because you're making not a decision like the space shuttle, but you're making a big decision. And it's a big decision because you're trying to do something for the patient that's going to improve their quality of life and not create problems for them.
Right.
And so let's talk about how we limit sway.
Right.
I mean, what's the first thing that comes to mind on how we limit the sway?
First thing that comes to mind is our data collection.
Yeah.
Yeah, we get the x-rays, the photos, the scan. We do thorough data collection in our exams. So we have all the information to make informed decisions that are best for that individual patient.
Well, what would be the next part of the data collection? I mean, what do we do with that data?
Yeah, it's a lot of data. It's a lot that we get. And when you come to our exams, you're like, well, this is a lot of dentistry we're talking about. So we end up categorizing that data into 4 risk categories.
Exactly.
And that helps us see things in those categories to figure out the best course of action. And those 4 categories we've talked about before. First one, yeah, they're really important in our office. It's part of our culture, those 4 categories. And you'll hear us talk about it. We'll ask, all right, what's the risk profile here? And we'll go back in our notes and we have it all documented. So those 4 categories, biological risk, a periodontal risk, functional risk, and aesthetic risk.
Yeah, so right away, because we use this template so much, it really helps in decision making.
Mm-hmm.
And so like a common example, it's a case in point that we're actually treating today, and we'll pull up a photo on this, is, a common question is, Doc, do I really need a crown? And it's like, when I first started, I'm wanting to please the patient. I want to save the money, right? And crown is more than a filling. It takes more time, takes 2 visits typically. And there's bias there. Yeah, I want to be able, I think we can we can do a filling. That's sway. And it may not be in the patient's best interest to do that. So with this system, and in this particular situation, we had these 2 teeth that hit our radar.
Yeah, right away.
And they both have old fillings. And like if you look at this one here, first thing is we look at, does it meet the criteria for even needing to be addressed? And what do we always say about the criteria?
There's 3 criteria, especially when it has an existing filling. Is that filling cracked?
Right.
Is it leaking where it has some cavities around it, or is the tooth itself cracked?
Exactly. So right away, that gives us no sway on does the tooth need to be treated. Because this particular tooth, what do you see?
I see that leakage, that shadowing around that existing filling.
That's leakage.
And it has a bit of a crack in it.
A little bit of a crack that's subtle. A lot of times when I see these cracks, because I know what's underneath there a lot of time, a patient may look at it and I don't see the crack. But we know when we see something that's a hairline crack, what we call craze line, would you do a filling on this or would you do a crown?
And so for me, this is going to be maybe more game time decision.
Yeah.
Yeah.
But I agree. So we use that term, a game time decision, right? That we don't know until we kind of have the hood up and see what's underneath there. So, on a tooth like this, I would agree. I would treatment plan this with the patient of, we're going in, most likely this is going to be a filling. When would we make the game time decision to do a crown?
Once the hood is up, so that filling is out and we're able to take a look and see the decay is gone and we're cleaning it up. If we see that fracture line, if we see a crack going through the tooth from the mesial distal or from the front side to the back side of that tooth.
And if it continues underneath the filling, sometimes you clean it up and the crack just goes away. Easy decision.
Yeah, filling.
We're doing a filling. What's the function of the filling?
It seals the tooth.
Seals the tooth. What does it do to the integrity of the tooth? Does it strengthen it? Does it weaken it? Does it stay the same?
I'd say about the same. It helps a little with strength, but it's mainly that seal of that area that we just cleaned up.
What's the function of the crown?
Crown is strength. It really does give more integrity to the tooth.
Covers the tooth, holds the tooth together, right? And so if this is a patient that has a low functional risk, does that lean in favor of a filling or a crown?
Filling.
Filling, yeah.
Yeah.
There's a low functional risk. If I get in there and I see that there's a little bit of a game time decision to make on, the crack, still see a little bit of the crack there when the filling's all gone, but now we're going to the intangibles. We look at this lady, she may be 80 years old. She doesn't have a lot of musculature that's tense.
Right.
She doesn't have a lot of those, like we talk about on carpet, the traffic areas on the tooth. I'm fine with a filling all day long, no sway.
Right.
On this particular patient, you remember her risk profile?
It's a high functional risk.
High functional risk, and part of that came from the data collection of a history of fractured teeth. History tends to repeat itself. And also, what we see on one side of the mouth, on the analogous tooth on the other side of the mouth. In other words, if she has all second molars that have cracked, and you see one on the other side that's starting to crack, you know it's going to need a crown
Right.
because the other side already had a root canal and a crown.
Mm-hmm. Yeah, what happens on one side tends to happen on the other.
Yes, so that helps us, and it prevents sway when the patient's like, do I really need another crown? Yes, Mrs. Jones, it's going to be in your best interest to do that. In the long term, you're going to save money and time
Mm-hmm.
and stress and trauma.
Mm-hmm.
And I can look you in the eyes and tell you it's going to be in your best interest. And again, we have a long-term relationship. So I'm going to want to do things that are going to pay off for you. And once you establish that type of relationship, it starts to hum, right? You're not having to struggle, and the patient knows that you're doing something that's going to help them. And the only reason they're there that day,
They want to save the tooth.
they want to save the tooth, and we want to give them 100 with all their teeth.
Yeah.
And the chance of doing that on this particular patient
Mm-hmm.
is pretty slim, right? So let's go to the other side.
Oh, yeah.
What do you think about this one?
So this one, large existing filling, see that shadowing, got some leakage. And this one right off the bat, no sway, we do a crown.
I agree. Yeah.
Yeah, and the reason being is you take a look at how much of that tooth is now this filling material, and the way that we do it in a tangible measurement is we look at the isthmus, so how much of that tooth is the composite, so from one cusp tip to the other. And it's enough where we can't just do another filling on there. It needs some full coverage.
Yeah, and also when we do what we call the blue bite, when we see what the traffic areas are on that tooth, if they're working to wedge the tooth apart from the opposing tooth, that's another thing where it's like, needs a crown. We're going to do build up and crown. And it helps because the day that we go in to do the treatment, we have clarity. We have clarity. Not only do we have clarity,
The patient
the
does
patient
as well.
has clarity. And that gives us good mojo, right?
Yeah,
We go in there and get the work done. We ask the patient, do you know why you're here?
and they do.
They
they're-
know why, and they know why they're sitting down in the chair, investing the emotional energy, the time, and the money. And when we know that, and we're working together, it's just not me dragging you in here and you trying to optimize your insurance. It's you're trying to get sequentially a little bit better in your dental health, as opposed to making one step forward and two steps back, right? So if you did a filling on this tooth, may buy you some temporary, I did something good, but you come in with an emergency and the tooth cracked down the middle, which is a catastrophic problem. We've taken not two steps back, we've gone down a rabbit hole now.
Right, yeah. Some time and money has been invested, and now more time and money needs to be invested to try to save that tooth. And then the worst case scenario, we can't save the tooth.
Yeah. So for the most part, we try to stay two steps ahead of a problem. And, it starts with the new patient exam, like we always say. And sometimes I think it's important to note, we just did a case yesterday where a young lady came in, because not everybody is ready to come in for the new patient full exam of the data collection, the co-diagnosis, tour of the mouth, and the review of findings. Not everybody's ready for that. They may have a lot of things going on, maybe a young expecting mother, and this is the case for this young lady that came in yesterday, and we started with her with an emergency situation. That's all she could do at the time. She was pregnant, under a lot of stress, had a problem with the front tooth. It's a little stressful on us, especially working on a front tooth on somebody who we haven't done the data collection on. We don't have the diagnostic information to make good decisions, and we have to jump into something. But we realize that's real life. And so we started with this young lady with 4 front teeth, had struggles with the case, and there was doubt from her, and there was sway in my mind of what needed to be done. We made it through that. We became good friends, developed a relationship, and now she's back after 2 years to finally do it the right way.
Yeah, start with that data collection and go through our co-diagnosis and review of findings.
And guess what? We're at a whole nother level of our relationship. So now I don't have to drag her along, because child's been born, she's at a better state now, we know each other, we've been through thick and thin. Now we can make decisions together, and we have simpatico, we have flow. So, just another example of the nuances of this whole thing that we talk about all the time with the risk assessment and some of the buzzwords like sway and what's under the hood and game time decision, that hopefully helps patients understand what goes in to making these decisions. As I say, I'm not diagnosing your pocketbook, I'm diagnosing the problem.
Right. My favorite part is it's patient, individualized to the patient, patient-focused care.
It really is catered to the individual.
Yeah.
Like I say, it's not like you're going through an algorithm where you have a flow chart and you're following the flow chart. I mean, in concept, that's great.
Mm-hmm.
I don't think it works well in dentistry just to follow this algorithm and to be unwavering and not have the ability to make game time decisions because you're locked into a flow chart. Doesn't work, there's too many intangibles, so we start with that concept, but we're able to make changes and not have sway based on the data collection on the risk assessment.
Right.